So our first presenter is Angel Nkwain. She comes to Johns Hopkins from Cornell University, where she received a bachelor's degree in science in human biology, health and society. Her topic today is the use of misoprostol to prevent postpartum hemorrhage in low resource settings. So Angel, the floor is yours.
Thank you so much for the introduction, Dr. Donahue. Good afternoon, everyone. I'm Angel Nkwain, and I'll be presenting on a literature review I conducted on the use of misoprostol to address postpartum hemorrhage in low resource settings. As a short overview, I'll be covering the background information regarding postpartum hemorrhage and misoprostol use in low resource settings, and the methods used for my literature review, the results and discussions, as well as a conclusion and any recommendations and considerations to be taken in the future. First, postpartum hemorrhage, also referred to as PPH, is typically defined as the blood loss of 500 milliliters or more within 24 hours of a vaginal birth. PPH is the leading cause of maternal mortality across the world, responsible for more than 25% of deaths annually, impacting around 14 million women each year, particularly in low-income countries, and resulting in approximately 70,000 maternal deaths globally. In addition, about 95% of all maternal deaths occur in low and lower middle income countries in 2020, with 70% occurring in sub-Saharan Africa and a little over 15% in Southern Asia. Many maternal deaths are preventable and can be addressed using existing clinical knowledge and technology, but interventions to reduce these deaths are often not accessible, particularly in low resource settings. Progress in addressing maternal health concerns is often stalled by proximal causes in many of these low resource settings, including the high burden of obstetric causes like postpartum hemorrhage. PPH has persisted in low-income countries with little change, partially because of the prevalence of home deliveries and insufficient availability of life-saving uterotonic medications during these deliveries. As oxytocin, the leading uterotonic drug, often requires proper storage and administration by skilled birth attendant and sufficient supply. Misoprostol is a prostaglandin E1 analog, another uterotonic that can be used as an alternative intervention to prevent and treat PPH. Misoprostol has a long shelf life and multiple methods of administration, allowing for its suitability for distribution in low resource settings by limited skilled workers. Although evidence exists for the use of misoprostol in facility settings, as well as its use with oxytocin and other uterotonics in addressing PPH, there is limited information on the role of misoprostol when administering it outside of facilities or outside of hospitals and instead at home. So the objective of this literature review was to examine existing evidence from randomized controlled trials on the efficacy of misoprostol in the prevention and treatment of PPH, as well as any considerations and challenges for the implementation of misoprostol in low resource settings. Onto my methods, I first searched PubMed clinical queries for literature on RCTs using the search terms postpartum hemorrhage and misoprostol, and this resulted in 160 studies. The main studies included were RCTs comparing oral and sublingual misoprostol to a placebo for vaginal births at home. And it also included equivalence trials comparing oxytocin and misoprostol for vaginal births in facility. These studies were included and excluded other forms of administration of misoprostol, use of misoprostol with any other type of medical procedure or other uterotonics, Studies assessing other conditions other than PPH were also excluded, as well as C-sections. On to the results and discussion. Only 5 RCTs for the placebo-controlled trials met the criteria, and these studies had a range of countries included, and these were primarily in rural areas. The RCTs varied in the dose of misoprostol that was used, the delivery method, as well as the timing of administration. Of the placebo-controlled trials, only 2 of the 5 studies measured using the primary outcome of blood loss greater than 500 milliliters, and these had quite large sample sizes. And these 2 studies found that there was a significant reduction in the incidence of PPH and mean blood loss when comparing misoprostol to the placebo. The remaining studies measured the drop in hemoglobin level as their primary outcome and concluded that there was no significant difference between the misoprostol and placebo groups. However, these studies had a sample size of less than 90 women. In most studies, though, community health workers, midwives, traditional birth attendants were all supervised and trained to administer misoprostol correctly. And one study educated women on how to self-administer and found no difference reported between the misoprostol and placebo groups. As for the equivalence trials, 9 randomized controlled trials comparing oxytocin and misoprostol were examined, and these also varied in the dose of misoprostol, the delivery method, and the timing of administration. And most of the studies found that there was no significant difference between the 2 treatments in the frequency of PPH, blood loss, as well as changes in hemoglobin. And only one study found that oxytocin was more effective than misoprostol in reducing blood loss and preventing PPH. However, this study also had the lowest sample size. Some studies were double-blind designs that helped reduce any bias in the study. And however, some studies were not adequately powered to distinguish between severe PPH, blood transfusions, or other clinically significant outcomes. Onto my conclusion, this literature review provided a comprehensive analysis of the available literature on the use of misoprostol for prevention and treatment of PPH, and they provided key insights into the use of misoprostol, its implementation, as well as its safety. Although oxytocin may still be the recommendation for prevention and treatment of PPH, misoprostol is a possible alternative for use when oxytocin is not available, as most studies did not find significant differences between the 2 drugs when used in facility settings. As for limitations, there were variations in the study methods. A small number of PPH cases in some studies challenged the validity of the comparisons. And in some of the studies, they didn't measure the primary outcome as blood loss. As for considerations, this includes low cost, ease of administration, stability, and the positive safety of misoprostol, making it a good option for low resource settings and for at-home births. A lot of studies cited minimal symptoms of shivering and fever when misoprostol was taken, so management of these side effects should be taken into account when implementing. As for recommendations, the WHO still recommends using 400 or 600 micrograms when administering misoprostol, and community engagement and collaboration involving healthcare providers, policymakers, and community members is key to the implementation of misoprostol in home births. And this can include, raising awareness and addressing stigma, as well as, promoting overall safety. A major concern, though, is misoprostol use in abortion services, and educating communities and women about misoprostol use is vital for the proper implementation of misoprostol administration. Lastly, research on the use in home births may be needed as limited studies were available, as well as on the optimal time for administration, the management of side effects, and possible self-administration. That's the end of my presentation. So I'd like to acknowledge and give a special thanks to the amazing people who supported me throughout this process. First, my reader, Dr. Strubino, for her patience and her guidance throughout writing and presenting this essay. My advisor, Dr. Donahue, for her encouragement and her support always. Ms. McCormick and the whole PopFam department for helping me keep on track in my course, as well as my classmates and friends who encouraged me throughout, and my wonderful family and friends and loved ones who might be on the call right now. So thank you all so much for your support.
Thank you, Angel. Nicely done.
The question revolved around the stigma related to abortion issues and distribution of the life-saving medications or medicines. And Jovial asked this question.
Okay, thank you for the question. I first really chose this topic because it was very relevant to my field placement with USAID, and I was able to, really see how countries thought about misoprostol and its implementation. And I think because misoprostol is one of the key drugs used for abortion services, it definitely impacted how policies revolving misoprostol were dealt with. And even though it can be so important in addressing PPH, so yeah, I think that it's definitely important in educating people about misoprostol use and how important and vital it can be. So thank you so much for that question, Jovial.
And Chelsea had a question about the differences in the timing of administration of misoprostol.
Yeah, so a lot of the studies varied in when they administered misoprostol. Some of them gave it as a prophylaxis. Some of them did it prior to cord clamping. But yeah, it definitely varied throughout the studies. And I think it's also an area that needs to be expanded on in future studies.
Thank you so much, Angel. That was fantastic.
Thank you all.
So our next presentation is by Anya, Scott-Wallace. Anya comes to us from Vassar, where she earned a bachelor's degree in psychological science and biology. And she's going to talk this afternoon on can expansion of nurse-midwifery care improve birth outcomes of marginalized populations in the United States, a systematic review.
My name is Anya Scott-Wallace, and today I will be presenting on my thesis project titled Can Expansion of Nurse-Midwifery Care Improve Birth Outcomes of Marginalized Populations in the United States, a systematic review. So I will quickly go over the agenda for this presentation. I will start with the background, during which I will explain a few key terms, the significance, and the objectives. After that, I will move on to the methods, which will include the eligibility criteria and the PRISMA literature search. Next, I will go over the results, which includes the study characteristics and outcome results. And then finally, the discussion, which includes strengths and limitations, conclusions, implications, and recommendations. So a few key terms that I will use throughout this presentation include CNM, which refers to Certified Nurse Midwife, PTB, which refers to preterm birth, LBW, which refers to low birth weight, SES, which refers to socioeconomic status, and RAM, which refers to racial and ethnic minority. So the significance of the issue, the US suffers from maternal outcome disparities, and this can be shown by the maternal and infant outcomes in Black, Indigenous, and low socioeconomic women, such as Black and Indigenous women being 2 to 3 times more likely to die during childbirth than white women, as well as Black and Indigenous women and Medicaid beneficiaries having higher rates of PTB, LBW, and being more likely to receive late or no prenatal care compared to the overall population. But midwifery-led care is thought to be an equal or preferable alternative to physician-led care in order to decrease these health disparities. And this leads me to the objectives. So the objectives of this review were to compare birth outcomes of nurse midwifery-led care models to other models of care, and to assess whether the nurse midwifery-led care models show improvement in birth outcomes and marginalized populations, specifically REM and low SES, compared to other models. So a little bit about midwifery. The World Health Organization defines midwifery as skilled, knowledgeable, and compassionate care for childbearing women, newborn infants, and families across the continuum, from pre-pregnancy, pregnancy, birth, postpartum, to the early weeks of life. So CNMs are the most prevalent type of midwife in the US, and they are professionally trained, accredited midwives that also hold a degree in nursing, and they can practice in all 50 states and Washington, DC. About 10% of all US births are attended by CNMs, and about the same for Medicaid-funded births and Black births, and about double for Indigenous births. So for this review, studies included randomized control trials and cohort studies, and all women included in the studies in this review were low to moderate risk, so not including women with comorbidities or high-risk pregnancies. And this review also included models of midwifery, such as caseload midwifery and standard care midwifery supported by CNMs, if in the US, or if the studies were outside of the US, then and they didn't use the CNM model, then just a professionally trained midwife. And the reviews the studies were also required to take place in either a hospital or birth center, so studies in the home setting were excluded from this review. So the literature search started out with about 6,000 studies, and after the removal of duplicates, the screening of abstracts and titles, and full text reviews, I was left with a total of 16 articles, and 14 of which were unique studies. So a little bit about the study characteristics. 8 of the studies were set in the US, 3 were set in Australia, 2 in Denmark, and 1 each in Canada, Scotland, and England. And the designs of the studies included 9 retrospective cohort, 6 prospective cohort, and 1 randomized control trial. And there were 2 intervention settings. So 8 of the studies were set in hospitals, and 8 were set in birth centers. So moving on to the outcomes. This review assessed both newborn and maternal outcomes, and the maternal outcomes of interest included induction, augmentation, and readmission. So after adjusting for socio-demographic factors such as age, education, and parity, the following results were found. So 4 out of the 5 studies that assessed induction, 4 out of the 9 studies that assessed augmentation found significantly lower rates in the groups where women were attended by midwives compared to standard care. And then both of the studies that assessed readmission found no significant differences between the rates of readmission between the 2 groups. For newborn birth, the review assessed low LBW, PTB, NICU admission, length of hospital stay, and readmission. So for LBW, 4 out of the 6 studies found significantly lower rates in midwives, and for PTB, 3 out of the 4 studies found significantly lower rates for midwives, and for NICU admission, 2 out of the 7 studies found significantly lower rates for midwives. In terms of readmission, there was only 1 study that assessed readmission, and there was no significant difference between the 2 groups. And in terms of length of stay, 1 out of the 4 studies found a significantly lower rate in women who were attended by physicians as compared to midwives. So of the 16 articles, only 4 assessed outcomes for marginalized populations. So in terms of REMs, 1 study showed lower mean birth weight for non-white newborns with differences greater at the maternity center, and another study showed more favorable birth outcomes for African-American women in midwifery care. In terms of low SES, 1 study showed a lower birth weight infants for women who had medical assistance or were self-paying compared to those with private insurance. And another found that there was a lower risk of very low birth weight for Medicaid recipients. 1 study also found that high school education or less increased the risk of lower birth weight compared to college education or more, regardless of birth attendant. And finally, 1 study found that there was no significant difference between mothers with no post-secondary education and mothers with post-secondary education for maternal and newborn outcomes. So a few strengths of this review included intention to treat to account for potential confounding, collaboration with an expert in the field, and half of the studies were set in the US. On the other hand, a few limitations included limited research about midwifery-led care for marginalized population, the study designs with most of the studies being cohort studies, and study settings with half of the studies set outside of the US. So in conclusion, results were fairly inconsistent between the between the studies, and there is limited data regarding REMs in people of low SES. So onto some implications. Midwifery has been shown to increase satisfaction in care and childbirth experience, as well as allow the woman to feel more in control during birth. But there are nevertheless barriers for midwives to practice and provide care, such as lack of autonomy, lack of support in the work environment and care continuum, and limited financial compensation for work hours and work done. But also nurse midwifery care has been shown to be cost-effective overall. And as previously stated, there are significant research gaps surrounding midwifery care, particularly for marginalized populations. So additional research that focuses on REMs and low SES individuals is necessary. So there are 3 recommendations made to ensure accessibility of midwifery care. So the first recommendation is to address social barriers by dispelling common myths and increasing knowledge and awareness. The second is to target lack of accessibility by increasing the workforce. And this can be done by promoting CNM educational programs for all qualified individuals, by creating federal and state funding streams, such as grants for current and new CNM training programs, and scholarships for individuals to attend these programs. And finally, increasing Medicaid fee-for-service rates for midwives to 100% of physicians' fee-of-service rate. So to end, I would like to thank a few people who were instrumental for me getting here today. So I would like to thank my reader, Donna Strubino, who has guided me through this entire process, my peers in the PopFam department, and I will also like to thank the TMA team at CMCS, which is where I had my field placement, for allowing me to join their team and accepting me and guiding me through that. And then finally, I would like to thank my family and friends, and a special shout out to my mom, who have always supported me. So that concludes my presentation, and I would like to thank you all for your time and attention, and leave room for any questions.
Thank you very much, Anya. Very nicely done. I see we have a hand raised with a question right away. Emily, would you like to go ahead?
Yeah, sure. Thanks, Anya, for that presentation. It was really interesting. So you mentioned for the marginalized populations that you were focusing on low SES populations and racial ethnic minorities. And then I was just kind of thinking through like what other populations might have, differential access. So have you thought anything about the maternity gap in rural populations?
Yeah, so that's a great point. I was actually thinking initially of adding rural populations, but there is very limited research on rural populations, like even less than low SES and REM populations. So I opted out of including that, but that is definitely something that I should have possibly included, and I could have just noted that there's limited research surrounding the rural populations, because it is important to note the maternity gap in rural populations, and that's also somewhere where we could definitely use more research.
Thank you.
Jamili, would you like to go next?
Yes. Hi, I have a question. You talked about your eligibility criteria, and I really want to know the difference between standard midwifery care versus like caseload midwifery care. Thank you.
Yeah, so that's a good question. Caseload midwifery refers to the model of care where there's one midwife who attends you, who helps you throughout your entire pregnancy journey, so antenatal, intrapartum, and postpartum. And then there's they also work with a co-midwife who would just be like a backup midwife. So whereas standard care is similar to like working with like an obstetrician, where you don't have that one midwife who works with you throughout the entire time. It's just essentially who's ever on call at that time. Yeah, unfortunately, I didn't get to distinguish between the two as much in my review, but that's definitely something I would also think would be interesting to look into as well.
Really great job.
Thanks.
I had a quick question. So you talked about a little bit earlier about like dispelling the myths as a method to increase this midwifery-led care. I was just curious if you happen to look into any sort of like specific reasons as to why the women are not using the midwives.
Yeah, so that can kind of date back to, yeah, I would say that kind of dates back to around like the 1900s, where there was that shift between from midwifery care to more hospitalized care. There was, that time created a lot of stigma related to midwives, such as them being untrained and like uneducated and like unsanitary. And I think a lot of that stigma has kind of stayed with us today, as well as women also wanting to be, or birthing people wanting to be comfortable during childbirth, specifically in terms of, medication, so that they don't feel the pain. And then there's also the fact that sometimes some insurance, they don't provide midwifery. They don't cover midwifery care, so that also acts as a barrier, because if they can't afford it out of pocket. So those are just a few reasons why women aren't using midwives as much.
Great, thank you.
Thank you. Anya, we're going to have to stop there. So well done. Again, a little applause for you. So thanks again. So our next presenter is Monika Watat. She's one of our own, comes from Johns Hopkins University, where she received her undergraduate degree in public health. There's a surprise for us all. She is going to talk today about exploring the prospective relationship between psychosocial beliefs in adolescence and later parenting in Baltimore City. And I see she's already bringing up her slides. So it's all yours, Monika.
Thank you, Dr. Donahue, for that introduction. And hello, everyone. So today I will be presenting on my master's project, which is titled Examining the Prospective Relationship Between Locus of Control and Self-Worth in Adolescence and Later Parenting in Baltimore City. So first, we can just start with some definitions. So self-worth or self-esteem refers to a general satisfaction with oneself as a person. And then locus of control is something that can be internal or external, and this refers to the degree to which someone believes they have control over the events that affect their life. And psychosocial development is a term that encompasses both. So a bit more on psychosocial development. This field of study stems from a theory developed by Erik Erikson. And essentially, there are 8 stages that an individual goes through throughout their lifetime, and personality develops through these 8 stages. However, let's say there is a failure to successfully complete a stage that can result in later unhealthy personality traits or sense of self. However, this is something that is also malleable throughout your lifetime. So we see that this is really in line with the life course perspective that we like in public health, because it takes into account that health and well-being reflects cumulative life conditions, both internally and externally. And on this side here, we see that adolescence occurs in stages 4 and 5, in which one develops their sense of self-confidence and identity. So some prior knowledge on self-worth and locus of control. Among children and adolescents, lower self-worth has been linked to difficulty with relationships, anxiety and depression, academic challenges, and risk-taking behaviors. And similarly, lower control-related beliefs have been linked to aggression and delinquency, internalizing problems, substance abuse, and suicide attempts. So we know that psychosocial development in adolescence, which includes self-worth and self-control, has been linked to a variety of later outcomes, including contraceptive use. But to date, its relation to both timing of parenthood and parenting behavior has not really been explored in detail. We also know that parenting behavior is a key intergenerational mechanism of health and well-being. So therefore, we aim to examine whether self-rated locus of control and self-worth in adolescence are associated with later parenting behaviors in adulthood. So to do this work, we use data from the Baltimore Prevention Interventions Program, and our participants were part of the 2nd generation cohort. They participated in a randomized control trial of 2 universal preventive interventions implemented across 9 Baltimore City public schools when they were in the 1st grade. And these interventions were designed to reduce early risk behaviors related to poor achievement and aggressive behaviors. So our participants were then followed longitudinally and in adulthood as part of the Baltimore Generations Project, which is a follow-up study to the prevention program. They were asked to report whether they were biological parents and to report on their parenting behaviors. So these are the main questions that we aim to ask with our research. The first was, are adolescent psychosocial beliefs associated with becoming a parent? Are they associated with an earlier transition to parenthood? And then, are adolescent psychosocial beliefs associated with certain parenting behaviors? So now here are our measures. We looked at adolescence as it occurred in the 9th grade. We know that adolescents can range from 10 years old to like 18 or 19. However, we were really interested in looking at how these measures would show up in the 9th grade as that transition point between middle school to high school, where students have a little bit more freedom, both inside and outside of the classroom. To measure self-worth, we use harder self-perception profile for children as reported in the 9th grade, which are self-report scales used to measure child and adolescent self-worth, sense of self-worth, and self-competence. And then for self-control, we use the control and contingency related belief scale as reported in the 9th grade. And again, this is a self-report questionnaire used to measure adolescent perceived control. For early transition to parenthood, we looked at becoming a parent before the age of 18. And again, we used 18 because it signifies a bit of a transition point. At 18, yes, you're still a teenager, but in the eyes of the law and society, you just have a bit more responsibility and freedom. And then for parenting style, we use the structured interview of parent management skills and practices, which is a survey. And from this survey, we looked at parental discipline consistency and the enjoyment of parenting. So for our methods, our independent variables were self-worth and self-control as they were reported in the 9th grade. Our dependent variables were becoming a parent and early transition to parenthood, as well as parental discipline consistency and the enjoyment of parenting. And then we also looked at the covariates of race, gender, and intervention status, just to see how these factors would relate to or influence the relationships that we were looking at. And then for analysis, we performed unadjusted and adjusted multivariable logistic regression using Stata for looking at becoming a parent and early transition to parenthood. And then for parental discipline consistency and the enjoyment of parenting, we use unadjusted and adjusted multivariable linear regression using Stata. So here are some demographic characteristics for our sample. We had 340 in total become parents, and we had 85 experience that early transition to parenting as we defined it. And I'd also like to point out that our sample was majority female and majority Black. So now getting into some of our results. This was looking at the relationship between locus of control and becoming a parent, and we found that this was not significant. However, after we controlled for locus of control, race, and intervention status, we did see that women were more likely to become parents than men. And now this is looking at locus of control and its relationship to early parenting. And in adjusted and unadjusted models, we found that this relationship was not significant. However, after controlling for locus of control, gender, and intervention status, we did see that white participants were more likely to have an early transition to parenthood than Black participants. And now looking at self-worth and its relationship to becoming a parent, again, we saw that in unadjusted and adjusted models, this relationship was not significant. However, after we controlled for self-worth, race, and intervention status, women were more likely to become parents than men. And then for self-worth and early parenting, again, this relationship was not significant. However, after controlling for self-worth, gender, and intervention status, we saw that white participants were more likely to have an earlier transition to parenthood than Black participants. And now moving on to some of those parenting behaviors. When we looked at the relationship between locus of control and enjoyment of parenting, this was not significant in both unadjusted and adjusted models. Similar to parental discipline consistency, this relationship with locus of control was not significant in unadjusted and adjusted models. And then when we looked at self-worth and enjoyment of parenting, this relationship was not significant. However, we did see that after controlling for self-worth, race, and intervention status, men were more likely to report a higher enjoyment of parenting than women. And when we looked at self-worth and parental discipline consistency, this relationship was not significant. So I know that was a lot, but just to give a brief summary, we saw that self-rated measures of self-worth and self-control in adolescence were not prospectively associated with becoming a parent or early transition to parenthood, and neither were they associated with later enjoyment of parenting and parental discipline consistency. However, in some of the adjusted models, we did see that race and gender may influence becoming a parent, early transition to parenthood, and the enjoyment of parenting. So some strength of our study is that we were able to use like longitudinal data that spanned 25 years, and this sample included both mothers and fathers. Sometimes parenting studies can include one or the other, so I thought it was really good that we were able to include both. Some limitations are that we did study adolescence only as it appeared in the 9th grade, so there may have been things before or after that we just didn't capture in our analysis. Another limitation is that the SPPC, which is what we use to study self-worth, it was designed for children aged 8 to 12. However, in the 9th grade, you can be the average age is around 13 to 14. So while this is not, a huge age difference, there may have been certain nuances that we missed just because of that. And then additionally, our measures for parenting were limited to survey questions. Obviously, parenting is like a very complex, multidimensional thing. So there may have been some aspects that these questions were just not able to measure. And finally, we did have a smaller sample size, so we were not really able to look into moderation in terms of our analysis. So this was really the first step in exploring how psychosocial beliefs in adolescence are associated with later parenting behaviors, specifically in Baltimore City. Further research could include additional predictors, as well as more observational measures that are being collected through the Be More Gen project. And we hope that this type of research moving forward can inform programs, curriculums, and policies to better support individuals and families throughout their lifetimes. So I would just like to say thank you for one to the participants, because they've been in this study for a really long time. Big shout out to Baltimore City Public Schools and its teachers. It's Teacher Appreciation Week. My mom is a teacher and she's on this call. Thank you to my readers, Dr. Rochelle Muski and Dr. Sarah Johnson, as well as the entire Baltimore Generations team for all their help. And last but not least, big thank you to all my family and my friends for their support throughout this time.
Thank you, Monika. Well done. And welcome to your mom. So we've got a lot of hands up already. The first question, Emily, would you like to go first?
Sure, yes. Hi, Monika. Thanks for the presentation. It was awesome. I hope I'm remembering this abbreviation right. I think you mentioned the SPPC as maybe not the best thing to use for studying self-worth. I think that was on the limitation slide. So are there any other methods that you would suggest for evaluating adolescent self-worth that are maybe better?
Yeah, Emily, thank you for your question. You did get it right. So yeah, the SPPC, which stands for the Self-Perception Profile for Children, it was developed by Susan Harder, who's a researcher, and she actually also developed the Self-Perception Profile for Adolescents. And that one, she said, is specifically for adolescents ages 14 and up. And that one is a little bit different from the SPPC in that it also contains measures that relate to like attractiveness and like relationships with peers and maybe like a significant other and things like that. So that may have been like an interesting thing to have been able to ask the adolescents. However, I do want to say though that the SPPC is a common measure used to assess self-worth like across all ages of children. So I think it was still an accurate measure, but I do think that there may have been additional things that the SPPA, which is for adolescents, that maybe could have added to the study. But
thank you.
Yeah.
I think we are only going to have time for one more question. So Jamila, I think you got your hand up before Anya. Sorry, Anya.
Okay, Monika, great
presentation. I'm thinking about how you talked about enjoyment of parenting and parenting discipline and consistency. How did you like assess those two types of really parenting? Because you said before that it's very hard to understand how people parent and how they think about parenting.
Mm-hmm. Yeah, so for those two measures, for parental discipline consistency and the enjoyment of parenting, we use survey questions that parents answered as part of the Baltimore Generations Project. And we basically did like an average. So I know for the discipline consistency one, some of the questions were like, how often does your child get disciplined? Or like, how frequently does your child get away with things? And then for enjoyment of parenting, some things we looked at is like how pleasant is it to raise your child? Like, how well do you get along with your child? And we took those questions and did an average to then kind of assign scores and then use that for our analysis. And I did like the survey questions. I thought they were well written, and I like that it was like a Likert scale. But again, I think there are some things that survey questions just can't measure. And I think like something that would be really interesting to include in further analysis is something called the PCIT that we do for the Be More Gen project. And for that, we have parents and kids come in together and they do different activities together. And in one of them, the activities kind of get more restrictive to the child. So then we can really see how the parent and the child interact with each other under certain circumstances. So I think, maybe adding that and finding a way to make an overall score for qualitative and quantitative measures could be like a really interesting way to maybe, have a better understanding of like parenting behaviors.
Wonderful. Thank you, Monika. Well done again. So I'm afraid, Anya, thanks for taking your question offline with Monika. So our next presenter is Olivia Girvan. Olivia has a Bachelor of Science in Biopsychology, Cognition, and Neuroscience from the University of Michigan. And she is going to talk today about Fetal and Infant Mortality Review Quality of Care Checklist, a pilot project in Baltimore City. And she has her slides up already. So it's all yours, Olivia.
Great. Thank you for that introduction. So great to see everyone. My name is Olivia Girvan, and my master's essay is titled Fetal and Infant Mortality Review Quality of Care Checklist, a pilot project in Baltimore City. So first, let's start with some background on the problems guiding this work, which are fetal and infant mortality. Fetal mortality is the death of a fetus at 20 or more weeks gestational age per 1,000 live births and fetal deaths. And infant mortality is the death of an infant before 1 year of age per 1,000 live births. You can see that compared to the national rates, there's a pattern of higher fetal and infant mortality in Maryland, and even more so in Baltimore City. Data also shows clear Black-white disparities in fetal and infant mortality rates, with non-Hispanic Black birthing people and infants experiencing higher rates of these outcomes in the country, Maryland, and Baltimore City. And data not shown here indicate that non-Hispanic Black infants are more likely to experience the leading causes of mortality. Some proposed reasons for these disparities include pathways related to the social determinants of health, such as the association between experiences of racism and adverse birth outcomes, potentially through allostatic load, and the link between racial discrimination at a systems level manifesting as Black individuals having reduced access to resources. So moving from background on the problems, I'm now going to give some background on the Fetal and Infant Mortality Review, or FEMR program. So there are 160 programs nationally, with 7 in Maryland and 1 of those in Baltimore City. The purpose of all of them is the same. It's to review fetal and infant deaths, to identify factors that contributed to losses, and then make recommendations for specific systems change to prevent future deaths. Specifically in Baltimore City, the process starts when the local FEMR coordinator receives a case from the Maryland Department of Health. Then a public health nurse performs data abstraction using medical, public health, and social records, and de-identifies the data, which removes the patient's personal information and hospital and provider names. Each case is then presented at a 2-hour monthly FEMR meeting. Importantly, the members of Baltimore City's FEMR are multidisciplinary, so the team involves public health professionals, healthcare providers, representatives from hospitals, and local agencies and organizations, all focused on maternal and child health. Everyone volunteers their time. So with that background, I'll now introduce you to Baltimore City's FEMUR Quality of Care Checklist. The development of this checklist had two main drivers. First, Baltimore City FEMUR leadership wanted to find a way to track quality of care concerns in fetal and infant deaths after they read a paper by a national maternal mortality review working group. This paper discussed similar issues in maternal deaths and proposed ways to document the contributions of discrimination to disparities in pregnancy-related deaths. And this was interesting to the FEMUR team due to the stark Black-white disparities in fetal and infant mortality in Baltimore. Also, past literature on healthcare experiences among minority birthing people indicates that quality of care concerns related to unmet needs and discrimination exist, which impact fetal and infant mortality. So this drove development. So the checklist was created in early fall of 2022 with the goal to systematically track quality of care concerns and highlight systems failures that contributed to these losses. The content has 3 sections, which I'll go into next. And the process involves FEMUR members completing the checklist anonymously after each case review. So the first section, quality of care issues, asks FEMUR members to identify any issues present in the case, such as delays in treatment. It also asks if the issues contributed to the loss, meaning that they directly contributed to the cause of death. In the second section, care outcomes, FEMUR members identify if the birthing person had unmet needs in their care, such as needing family planning counseling. In the third section, implicit bias or discrimination, FEMUR members indicate if they believe that discrimination impacted the quality of care, and if yes, then they select reasons for that, such as body size. So the main part of my work involved completing a pilot project using this checklist. The objective was to review FEMUR cases from 2021 with the checklist to examine data trends and then inform future use of the tool. For the methods, a consensus team with 3 FEMUR members reviewed 5 cases with the checklist to reach consensus. So I'll now discuss results of the pilot project with a case presentation. And due to FEMUR confidentiality rules on a local and national level, to give you the relevant demographic and medical context, I've presented a theoretical patient that's representative but does not include direct information from any one case. This patient was a fetal death in utero at 23 weeks gestation after placental abruption to a 23-year-old Black birthing person with preeclampsia who had public insurance. Moving to the right of the slide, you'll see a completed checklist from a de-identified case we reviewed. For quality of care, the birthing person had multiple pregnancies affected by the same medical condition, with documented symptoms throughout prenatal care, but available medications were not given until after the loss, indicating delays in treatment and ignored or improperly treated symptoms. They were not referred to relevant specialists, despite documented comorbidities and multiple hospital visits for these, indicating a lack of appropriate referral or consultation. They did not receive a pregnancy risk assessment in Maryland, even though insurance required it, showing a lack of coordinated care. Care provided was not in their primary language and no interpreter was used, reflecting a failure to offer culturally congruent care. An overall lack of quality of care, marked as other, was seen due to the failure to address pregnancy history, comorbidities, language, and referral needs in the pregnancy care plan. Ultimately, 4 of these issues directly resulted in the fetal loss, so were coded as present and contributing. They did not have any unmet needs in their care outcomes, but consensus was that they experienced implicit bias or discrimination based on body size due to mistesting for a condition based on BMI, and language due to care not being delivered in their primary language. So in addition to each case's checklist, as we just saw, we also looked at aggregate data trends from the 5 checklists. This let us see that similar quality of care issues occurred in multiple cases per our review. 4 out of 5 dealt with delays in treatment and a lack of coordinated care. 3 out of 5 had their symptoms ignored or improperly treated, did not have their concerns addressed, and faced an overall lack of quality of care or other. And 2 out of 5 experienced a lack of appropriate referral or consultation. Only 1 case had care outcome concerns, which included unmet needs for family planning counseling, mental health support, and support for managing a health condition. Significantly, in all of the cases, implicit bias or discrimination likely impacted the quality of care based on our review. This was suspected due to race ethnicity in 3 of the 5, and body size in 2 of the 5 cases. The other suspected causes were less common, and each was present in 1 case. Next, I want to discuss strengths and limitations of the pilot project and the checklist in general. For strengths, our results reflect the current literature on reported healthcare experiences among minority birthing people, suggesting that the checklist could give a more comprehensive picture of their experiences in Baltimore. The checklist gathers standardized information about quality of care that could help inform FEMA recommendations. It also identifies aspects of the healthcare experience that may need improvement and can highlight instances of perceived discrimination that may impact quality of care. For limitations, although documented medical record data is used to generate checklists, what actually happened during each medical visit is unknown. So there's a level of subjectivity when we complete them. It takes a significant amount of time, up to an hour, to reach consensus on one checklist. And the project had a small sample size, which offers less robust data, but this was due in part to the time burden of reaching consensus. Lastly, to conduct the most thorough case review and ensure that each checklist reflects consensus among multiple people, FEMA relies on their diverse team. So the quality of the data may differ based on the number of FEMA members available to complete checklists. To conclude, the results of this pilot project indicate that the quality of care of pregnant people in Baltimore City needs improvement, and that implicit bias or discrimination may play a role in the quality of care. Given these results, the pilot project suggests that Baltimore City's FEMA complete checklists for all cases to collect and analyze more data, use this data to guide systems level recommendations, educate health professionals and organizations on identified problems, and with more data, consider the value of the checklist for other FEMAs in Maryland and nationally. In the end, these recommendations aim to improve the quality of care for all birthing people and reduce fetal and infant mortality and inequities in these outcomes in Baltimore City, Maryland, and the US. Thank you for listening. I want to give a special thanks to Dr. Pam Donahue, my first reader and advisor, the pilot project's consensus team who volunteered extra time to complete consensus review with me, and Baltimore City FEMA and the health department for giving me the opportunity to be part of the FEMA team and complete this project. And of course, all of my family and friends for their support throughout my education.
Thank you, Olivia. Well done.
Thank you.
Question?
Yes, hi Olivia. I wanted to say this was such a great presentation. I learned so much. And I guess my question is, like, do you know if the quality of care checklist is like currently being used by Baltimore City Fetal and Infant Mortality Review?
Yes, thank you. Great question. So after it was developed in late 2022, it has been used since then at their meetings, but there have been multiple iterations of the checklist, a lot of editing with feedback, and there was definitely a learning curve to learn how to use it. So we didn't want to use those completed checklists for this project. We wanted to go back to 2021 and dedicate time to looking at those old cases. So it is being used, but that data, they're not doing anything with it yet. They will use this project to inform what they do with it and see how they move forward with the checklist data.
I have a long history of working with sort of looking at the fetal and infant mortality reviews from a national level. And I'm particularly interested in sort of how that process actually informs maternal mortality reviews. So I had an interesting question with regard to, you know, it looks like you assumed that it was implicit bias happened, that you didn't actually have evidence in the case that it actually had happened.
So the way that when we go through the case review, I'm sure you know what the FEMA process is. So you know it's a long document of all their experiences. Right. And one of the key data sources is the maternal interview. And that gets their experience of their pregnancy, their postpartum, all the loss information. And so oftentimes in those interviews, mothers will share their experiences with healthcare and if they felt discriminated against based on certain factors. And so like for race and ethnicity, a data source like that is really helpful. But for specifically in the case I discussed, body size, for example, we selected that because based on medical guidance, there are certain testing that should be done based on BMI, and this person didn't get that. So then we assumed that there was implicit bias or discrimination based on body size. So we find something in the medical record to justify what we're selecting. But again, we only have what's documented. We'll never know what.
Yeah, and I think,
happened.
you know, the whole idea that you would actually, I don't know how you do it, but in the maternal interview, certainly if there were a way to try to document that there is discrimination or bias that is occurring in a way that doesn't explicitly ask the question so that you get biased results.
Right.
But it's I think it's a real challenge, but I think it's really important. And it's really important not only for the fetal and infant mortality reviews, but also for the maternal mortality reviews. But yeah, nice job. Nice
Thank
job.
you.
Yeah.
Thanks, Donna. And thank you, Olivia. I think we'll move along and we'll be right on schedule to finish. So well done. All right. Our last presenter today is Shoshana Oppenheim. Pardon me. She comes to us from Tufts University, where she got a bachelor's in science in cognitive brain and science studies. And she also did a master's degree in effective teaching, which is fantastic. So the floor is all yours, Shoshana. You're going to talk about police violence and youth traumatic stress, systemic review. It's all yours.
Thanks so much, Pam. So hi, everyone. I'm Shoshana, and I'm presenting our systematic review on police violence and youth traumatic stress. I completed this essay with Dr. Dylan Jackson as my first reader and Dr. Lindsay Webb as my second. Oh. Okay, so I want to start by going over some terms. So as a recently identified public health issue, police violence is defined as the use of excessive physical force or verbal assault and psychological intimidation. So this may include the use of deadly force, but also verbal harassment, including the use of racial slurs and intrusive practices like stop and frisk. People may be exposed to police violence directly as the subject of violence, vicariously as a witness to violence, or through social networks and media, or by anticipating a violent encounter. Police violence has increased nearly each year since tracking began in the early 2000s, but current surveillance only reports on fatalities and injuries, so we don't really have the full picture on police violence prevalence and especially its impacts on the youth population. However, we do know that young people are most likely to be stopped by police and are most exposed to police violence. A recent analysis of national survey data revealed that of the 19% of youth who reported being stopped by police, 9% were reported a direct exposure to police violence, and there were massive racial disparities. So Black and Hispanic teens, were nearly 3 times as likely to have a direct exposure to violence than their white peers, which shows that the way that police interact with youth of color is characteristically distinct. And this is in line with the United States history of the use of force and unequal treatment, discrimination, and profiling of Black individuals that continues to play out today, especially among young people. And so in thinking about, this body of evidence that we have about police violence and current mental health literature, police violence has been conceptualized as an adverse childhood experience, or ACE, given the danger and severity of these situations. Traumatic stress, which occurs when an individual's traumatic experience overwhelms their coping capacity, can play a role in the onset of post-traumatic stress disorder and can have major impacts on child and mental and physical development. So because traumatic stress is an important mediator in mental health outcomes and police violence is a traumatic event experienced by many young people, our systematic review seeks to gather the existing evidence on associations between police violence and traumatic stress in youth. So the way that we went about gathering our data was we had to start by creating a set of inclusion and exclusion criteria. I included the inclusion criteria here. So studies were included if they were published within the past 10 years in a peer-reviewed journal and included original empirical research using quantitative, qualitative, or mixed methods. Participants had to be between 12 and 25 years old and report a violent police exposure. The studies also needed to contain some sort of measure of traumatic stress. And finally, articles needed to be published in English with a sample from the US. So using those inclusion criteria, we put our search terms into 5 databases and used 2 screeners to review titles and abstracts. Then we reviewed the remaining articles, and those that met all of our search criteria were extracted for relevant information such as study design, context, methods, and measures. So given those methods and criteria, we went from over 9,000 studies to 21 included in the review. There were 11 quantitative studies, 9 qualitative, and 1 mixed methods that was examined as a qualitative study. As a broad overview, 10 out of the 11 quantitative studies found an association between police violence and traumatic stress using cohort, cross-sectional, and lab-based designs. And 10 out of the 10 qualitative studies found relationships between police violence and traumatic stress using semi-structured interviews, focus groups, and 1 cross-sectional survey. Through our synthesis of the research, we were able to further conceptualize direct, vicarious, and anticipated police violence exposure. So direct exposure was defined as youth being the subject of police violence. Vicarious exposure, we actually divided into 4 categories. The first was witnessing police violence in person. The second was unspecified family and community experiences. For example, participants would describe their friend being the subject of police violence, but in the interviews, it was unclear whether the participant witnessed this violence in person or heard about it later. Our third category was media exposure through social media images and videos. And finally, the last category of vicarious exposure we called macro level, which came from 1 study that used county level data on police involved killing as the measure of police violence. For anticipated exposure, this was defined as a fear of future exposure, either personal for the participant themselves or their fear for a loved one being the subject of future police violence. So here's a visual depiction of the type of exposure studied. Direct was the most common, but several studies actually explored multiple exposures at once, especially the qualitative studies. And I also want to note here that anticipated was really the least studied. And so we have less information about this type of exposure and how it may be distinct from direct and vicarious exposures. And then just to touch on measurement, traumatic stress was measured in 3 ways and across the studies. 2 studies used physiological stress measurements. 6 studies used various PTSD scales, and all of the qualitative studies used verbal descriptions of traumatic stress. And so we took those kind of interview and focus group transcripts and quotes and aligned those with PTSD symptoms from the DSM-5. Several patterns emerged in our synthesis. So first and foremost, all forms of police violence, direct, vicarious, and anticipated, were associated with traumatic stress in youth. And further, there's actually a dose-response relationship with the level of violence in an encounter leading to greater traumatic stress or being associated with greater traumatic stress. Youth of color were at greater risk for stress following a vicarious exposure. And we found through qualitative studies that it may be because they relate more to those who have a direct exposure in the media, or they themselves know someone with a direct exposure. We also currently have more literature on the unique experiences of male youth versus females. However, the relationship between gender, police violence, and trauma remains unclear. In considering other subgroups, many Black college students reported traumatic stress symptoms due to media exposure. And there was also differences for youth who reported low self-control, had greater traumatic stress following a violent exposure, and students who had experiences of suspension and expulsion were more likely to have a violent encounter with police and have traumatic stress. This review also revealed limitations in our current literature. So there's really an inconsistent use of metrics and measures across studies, and a lot of subgroups just weren't fully represented. There's a really large focus on males and not so much on females, and the sample populations mainly came from urban communities and the college setting. And then finally, just there's not a ton of literature in general on the specific impacts of police violence on youth, even though we know that youth have a lot of police violence exposure, and we know that there's great consequences of traumatic stress on the developing brain. So given our synthesis of the literature, we have several recommendations. The first is to fill the research gaps described. We need more research to better represent the youth population as a whole, so especially those with differential trauma and health risks, such as females, sex and gender minorities, youth with different cognitive profiles, and rural populations, to really capture the full scope of police violence exposure. And really, to do this research, that means we need to amp up our surveillance systems. And surveillance systems need to be comprehensive of police violence definitions beyond just injury and death, and really include the different types of exposures as well. Police violence has been named as a public health issue, and so our surveillance systems need to treat it as one. Secondly, several policy changes can also be enacted based on this research. So changes to policing practices in terms of when and how police interact with youth, and also considerations of ongoing youth-focused and evidence-based trainings should really be thought out and implemented. In schools, mental health practitioners must be available and trained to support youth who have a violent exposure to police. And also the use of culturally responsive ACEs screeners that include experiences of police violence can ensure that impacted youth are connected to needed resources and support, will be really helpful for supporting the youth population. And additionally, policymakers need to divert some of the large police budgets and growing police budgets to evidence-based alternative responder models that we know work and other social services. Finally, media outlets must plan how to depict police violence responsibly to minimize its traumatic effects on youth of color. So, in conclusion, we have a lot of evidence to show that police violence is associated with traumatic stress in youth, but many research gaps remain. Despite these gaps, we know that there is ample opportunity for policy change to support the mental health of youth and the effectiveness of community systems in supporting our young people. So I would like to thank Dr. Dylan Jackson and Dr. Lindsay Webb for their guidance, kindness, and feedback, and also dealing with my constant Teams messages. Also, thank you so much to the PopFam department for giving me the skills and knowledge to advance this work. And finally, thank you to my family and friends for keeping me sane and providing me with unconditional support as I worked on this project. I'll take questions now. Thank you.
Wonderful, Shoshana. Thank you. So, questions. We just have time for a couple. Ria, would you like to go first?
That was a really great presentation, Shoshana. I learned a lot. I guess one of my questions is, like, just out of curiosity, I'm just interested in knowing how you integrated your like quantitative and qualitative findings. Could you just talk a little bit about that?
Yeah, so really, you know, looked at each study separately and extracted relevant data, but we kind of found as we went through and brought the information together that the qualitative findings could really be used as a way to explain the quantitative findings. So for example, we found that in one quantitative study that females had greater anticipated exposure to police violence and greater traumatic stress symptoms than males. And in the one study that only looked at females, and it was specifically college students who were Black, they named that media exposure and kind of their reactions to media exposure was driving a lot of this anticipated exposure and related traumatic stress. So that's just like one example of how we use those qualitative interviews to better understand the quantitative data.
Thank you.
Mm-hmm.
And just quickly, because we're really out of time, but I want to give Yael an opportunity to ask a question. Please go ahead.
Thank you. Really great job, Shoshana. I just had a quick question. I think in your limitations, you talked about the use of males versus females. I was just wondering if you could talk a little bit more about why there was this greater focus on males, if you had a response to that.
Yeah. So in terms of the studies that we collected, most of them focused on males and females together, like they both were included. But some studies only looked at males and females alone, or males were the only sex of focus. And so there were 4 studies that focused just on male experiences and only one that focused on female experiences. And my guess for the reason for this is that right now the data are showing that males are more directly exposed to police violence. But there's also data to show that the amount of female violence exposure is really growing as well. And females experience different forms of police violence, as well as different types of exposures than males. So I think the literature just hasn't quite caught up to those changes, and especially in the youth population. So there is that research to show that this is happening for females overall, but we aren't quite seeing that yet with research towards youth. Does that answer the question?
Yeah, that's perfect. Thank you so much.
All right, we're going to have to end it there. Wonderful job, each and every one of you. Thank you so much. I learn something every time we have these presentations, and congratulations on finishing your essays and doing splendid work. So another round of applause for you all.